So what I would like to do is to give you first a brief introduction, how the pathophysiology of SARS-CoV infection shapes up, and followed by a clinical presentation. Then I will really focus on one of the formidable challenges of SARS-CoV infection, and that is the immune response. And then I will update the audience on clinical management. First of all, can you hear me? For somebody's, yes, okay, good. So this is what I'm going to accomplish today. Pathophysiology and clinical course in brief, followed by immune response, and then how clinical management in the context of supportive care is pursued. Let me start with pathophysiology. I would describe this slide one of the leading and most important slides ever we have produced, for a brief overview of pathophysiology of SARS-CoV-2 infection, which, by the way, appeared a couple months ago in the prestigious journal of Nature Medicine. So for all of us, there is no surprise that ACE2 actually serves as a receptor. Those of you physiologists, they know that ACE receptors exist throughout the body. As a matter of fact, there is more ACE receptors in our gastrointestinal system compared to respiratory system. So nevertheless, I do not want to go to molecular virology detail because of limitation of time I have. I wish I had a little bit more time, but that's fine. The virus enter through a very elaborative mechanism, and one of them is, a membrane enzyme which allows internalization of the virus to host cells. Then once this internalization takes place, you will see a direct effect of the virus, okay? In other words, direct cytotoxic effect of the virus. And that actually provokes a cascade of pathways, pathophysical pathways. Chief among them would be dysregulation of renin, angiotensin, aldosterone system, which in the next slide, I'll be talking about the specifics of it, followed by endothelial cell damage, which then consequently results in thromboinflammation, and then followed by dysregulation of the immune system. In that context, I'll be fully elaborating what do we mean by dysregulated immune response when it comes to immune response system. So you can see the take-home message from this introductory pathophysiological slide is that the insult by the virus is quite elaborative, quite extensive, and indeed the pathophysiology seems to be very complex, and it doesn't resemble other viruses of the RNA family. I have been in virology, clinical virology, actually, since my years in Pasteur Institute in France. Some of you probably read my biography. I'm a French graduate, and I never saw such a virus being so complex. And for example, we know very well now about the pathophysiology of HIV and even SARS-CoV-1 and Ebola and other viruses. But I can tell you for sure, I'm talking here with you, and I have a disclaimer. and that is, I am not an expert on this virus, okay? So, as far as renin-angiotensin-aldosterone system is concerned, again, back to our physiology, there are two peptide fragments. One would be the cleavage, which results to angiotensin 1 to 9. They primarily act as vasoconstrictor. And then we have, I call it the good one, the peptides between 7 and 8. These are the good ones, which primarily results to vasodilation. So you can see that 1 to 9 is pro-inflammatory, you know, and then 1 to 7 is anti-inflammatory. So this is the cartoon actually of angiotensin 1, okay, converting to angiotensin 2. We sometimes recommend ACE inhibitors depending on the clinical status and the type of, you know, hypertension or cardiomyopathy the patient may have. But the bulk of this cartoon is that there is some evidence, okay, there are few papers that the expression of ACE receptors may be higher in hypertensive patients or in diabetic patients or coronary heart disease, okay? So this is an area you will be hearing from me, areas of knowledge gap a lot throughout, because this is just a tip of iceberg. This is less than a year, at least, you know, in our Americas, you know, United States, Mexico, and on, you know, we are experiencing this virus for less than a year, although the Chinese are getting close to a year of the virus, you know. So this is an area which needs more clinical investigation and perhaps even, you know, fundamental research, you know, and how to translate that research into patient care, especially in the context of two classes of drugs. You know, one would be ACE inhibitors and the other would be, you know, receptor inhibitors. So then the second part was endothelial cell damage. Okay, well, first of all, ACE is expressed actually in the lung epithelial cells, okay? So the issue is alveoli. And here, if we just take a large zoom, you have an endothelial cells, you know, and it's divided by healthy alveoli and then, you know, injured alveoli. You can see from this section, there is a cascade, repeat, there's a cascade of inflammatory responses coupled by oxidative reactive species and coupled by, you know, immune response, you know, in the blood. In other words, you know, this is a very complex issue which you cannot, you know, explain by individual pathways, you know. They all contribute to the endothelial cell damage, and following the damage, then you will see dysregulation of endothelial cells. These are basically disrupted, and perhaps the disrupted endothelial cells is a mechanism where in some patient we see the leakage, you know, not all patients, in some patients. Especially I collaborate with a couple of hospitals in Milan and also in Madrid, you know, that is based on our observation of Italian and Spanish patients. So to summarize the endothelial aspects, okay, there's a disruption of the protective, you know, coating, and which results in alveolar instability. And that is indeed a recipe for acute respiratory disease syndrome, or ARDS, which really involves cytokine storm. Now, in addition to cytokine storm, you probably heard last month that from a British group and also from a German group that, the bradykinin storm is also under consideration. So if that is true, we need more clinical validation on that. So you will really have a more devastating pathophysiology effect, especially in the severe cases. So, and the last part on the first slide I showed you was dysregulation of immune response. Well, how can we assess that? The best assessment would be evaluation of inflammatory markers. I don't need to go over, all of you are familiar, such as C-reactive protein, ferritin, erythrocytes, sedimentation rate, D-dimer, fibrinogen, and LDH, but most importantly, this interleukin-6, which is also prognostic in severe cases, but many of us actually, we ignore the levels of albumin. Actually, many severe cases, you will see hypoalbuminemia, and also that correlates well with the severity of the disease, in particular, the DIC, disseminated intravascular coagulopathy, which is a different form of coagulopathy as opposed we see in bacterial infections and other viral infections. I will get into that slide and I will elaborate more on the DIC aspect. So you have a situation that are categorized as asymptomatic, then a mild to moderate, severe, and critical. And you have the viral phase as opposed to immune response. Okay, so in asymptomatic phase, yes, you do see a mild lymphopenia at the beginning, Then as the disease goes to moderate, especially at the end of moderate, you will see increased and significant lymphopenia. And this is where the D-dimer shoots up. Usually can go even up to 1,000 or more, Then we get in severe disease, not only there is a much more increased level of D-dimer, but C-reactive proteins are shooting up. And also there is a gas exchange issue here. I don't want to emphasize on blood oxygenation and gas exchange because of the time I have. I wish I had more time so we could elaborate, that. So what it means in the critical situation, all the inflammatory markers I indicated in previous slide, they are highly elevated and you have severe cytopenia. Now, with respect to severe cytopenia, I would caution you, in some patients, we do not see severe thrombocytopenia. And I will elaborate on that when it comes to that infamous DIC slide. So this, I would say, do not, especially for clinicians listening to me, and hospitalists and intensivists and critical care specialists, this is really a general picture, okay? Every patient has a case base, and really this paradigm shift may not be 100% representative of, for example, comorbid condition. Okay, so it may shift. For example, we have seen patients, that they start showing elevated CRP in this area rather than this area, or elevation of D-dimer in this area. So it all depends the immune response, individual immune response, but also what are the comorbid condition or conditions. We have got patients with cardiomyopathy, renal dysfunction, liver dysfunction, they certainly show elevation of inflammatory markers earlier than the last phase. I just wanted to caution you on that, So the other issue is the silent hypoxemia. As a matter of fact, the Chinese doctors and Italian doctors, they noticed hypoxemia, especially silent hypoxemia. While in silent hypoxemia, as you can tell, the patient feels kind of normal. He or she is not aware that the blood oxygenation saturation is going down. And as a matter of fact, if you give them your cell phone, they can dial you or they can talk to family members, and they don't notice, the clinical impact. So this is where we call it silent hypoxemia, and critical care doctors and intensivists can elaborate more on this aspect of COVID. So they also call it happy hypoxemia. This was from a journal of respiratory research. You can see that there are levels of hypoxemia, and especially, when the loss of lung perfusion regulation starts, that signifies, severe dyspnea. Then in a severe dyspnea, clinically speaking, you have a reduced lung compliance. I'll be talking about L-type and H-type later, and you have increased dead space that could be picked up by imaging and then consolidation. And some patients, yes, they develop atelectasis, and which leads eventually to fibrotic tissue in the lung, and of course, CO2 retention is a huge issue in hospitalized patients, and anxiety and fatigue comes with that hypoxemic, patient. Now, with respect to therapeutic intervention, this is very general, okay? But yes, when it comes to dyspnea and you see the level of fresh oxygen is very low, in consultation with critical care pulmonologist and ID specialist, you may initiate mechanical ventilation. We'll be talking about it a little bit later, but not in detail, because I know the third speaker will be talking about hospitalization of COVID in Yucatan, and I'm really looking forward to that presentation, because I think that would be a learning curve for me as well. Okay, so what it means, all of these so far I have described, the dysregulation of endothelial cells and also the hyperactive immune response brings about hypercoagulable state. And this is not actually specific to COVID infection. My colleagues can tell that this could be bacterial, or it could be any other, leading to sepsis. But what is important to recognize is, in the context of SARS-CoV-2 infection, the hypercoagulable state, let us say disseminated intravascular coagulopathy, is a result of multiple factors, okay? Starting with hyperviscosity of blood, and remember, there are all those chemicals and cytokines and byproducts ending up in the blood, and the blood is not capable of removing them, adequately, because they keep piling, Then we have a direct result of the virus, okay? In addition, there's a coagulation cascade, which leads to hypercoagulable state, including factor Van Willebrand or factor 8 Van Willebrand. Now, when it comes to factor 8 Van Willebrand, the role of this coagulation factor is not fully elucidated. As a matter of fact, a month ago, I wrote to British Society of Hematology. And some of you know I'm a French-trained hematologist as well. And I asked them perhaps to elaborate more on the role of not only this factor, but when it comes to activity of factor VIII von Willebrand, and also you know that, especially those hematologists, they know that, there's an enzymes breaks down this virus. So far, I haven't seen a peer-reviewed article not only about the role of this factor, but also the serum enzyme responsible for breakdown of this virus. And the reason I'm saying this, if we have a better picture of the product and the enzyme affecting on the product, we have a more brighter picture of what is going on in disseminated intravascular coagulopathy. So you can see there's a multitude of factors contributing to hypercoagulable state, including hypoxemia, and that is through a specific signaling pathway. We call it hypoxemia inducible factor. Now, with respect to antiphospholipid, well, I'm sure at the end of our presentation we're going to have debate on that. Okay. Antiphospholipid antibodies is transiently seen actually in bacterial infections, in other viral infections, and even sometimes in fungal infections. Okay, so with respect to antiphospholipid antibodies, I personally would like to know whether it's permanent. If it is permanent, is it going to be lupus-like clinical profile, or if it is transient? But most peer-reviewed articles that I reviewed so far, and also I'm in touch with French Hematological Society, most experts, they believe that probably this is transient, with the exception of 2 papers that describe this may not be transient. It could be, let me see. I see a Spanish message on the screen, but I'm going to ignore it because I don't know what it is. Buenos dias. Okay, all right. All right. So, because coagulation is one of the prime mechanisms of pathophysiology, let us summarize that. Yes, we see formation of thrombi more frequently in the veins than in arteries, so frequently VTE are seen, but also PE as well. But what is really striking in the immunology of COVID-19 is the virus is capable of producing immunothrombosis. Okay, so when it comes to this important pathophysiological, mechanism, neutrophils, they take major action. Okay, but also there is a network called neutrophil extracellular traps. As you can see here, this is a vessel. In addition to all these inflammatory markers and peripheral blood monocytes that are continuously producing net formation, as well as neutrophil activity and macrophage activity, all of them bring about, particularly peripheral mononuclear cells, they secrete this. So you have a fiber network. So you can see this is a very sluggish network. Primarily these are the product of DNA from neutrophils that they bind to any pathogen. For example, you may ask me, are they binding to only virus? No. You may have, and I want you to pay attention to this, you may have a situation, your patient may have superinfection, not only bacterial, but also viral. So the extent of net formation will be greater in those kind of patients. So as far as the lungs are concerned, the major issue is pulmonary shunt. So we have to go back to our physiology, and that primarily means there is, in many cases, perfusion, but no ventilation. So what it means, the ratio changes and you have an imbalance of the ratio. And let me go over. Now, when it comes to perfusion and ventilation ratio, the best professor in the world, I repeat, the best professor in the world, his name is Luciano Gattinoni. Some of you probably heard his name, Luciano Gattinoni. Luciano was in Milan, was a faculty in Milan, and then the Germans, they attracted him, and he worked in Germany, and now he's kind of semi-retired. But Professor Gattinoni again made a major contribution in COVID. He spends at least 50 years on the biophysics of the lungs, and he is regarded as one of the renowned and the best experts in not only in the physiology of the lung, but also pathology of the lung. So he's the one, in a paper a few months ago, which was published in Critical Care Medicine, characterized the pathophysiology in terms of lung pathology to L type and H phenotypes. Okay, so vast majority, again, don't reliably look at these percentages. This really varies from country to country. I'm sure in Merida this probably varies as well. Okay, so there are two characterizations when it comes to lung pathology. One is the L type. Anything L denotes to low. The other one is H type. It is simply a characterization. It is not a biological, definition, by the way. And anything would be high. In L types, you would expect low elastance. Well, compliance can be nearly normal, and some may dispute that. And I'll be happy if among you, if somebody is willing to dispute that, that's fine, because the goal of my presentation is we learn from each other, not just me talking. It's always better to learn from each other. Then the ratio of VQ changes to low perfusion in the alveoli. Okay, then you see the process of ground glass formation that could be picked up by CT scan. I'll be talking about CT scan a little bit more, and then you get a point, where there is a low non-rated, tissue. Well, that really signifies the fluid really accumulating in the lung, and the lung is progressing toward the collapse. As a matter of fact, if it progresses more, then you will see a second characterization, which is called H type. Compliance is low. Yes. Compliance is low, and there is a high lung weight, and this is not surprising because of the fluid accumulation, all those inflammatory cells, and especially you should also recognize that there are apoptotic processes going on simultaneously with this pathology, and that leads to lung recruitability, or increased non-irradiated. So the H type, you can describe it as a classic ARDS, the H type, So what is really the triggering point from transition to L type to H type? From my understanding and reviewing of more than 200 papers so far, edema is the main culprit for transition from L type to H type. Okay, so when it comes to blood oxygen level, okay, you have two areas, one would be normal, the other one would be low oxygen level. In L type, the patients basically, they respond well to inspired oxygen, okay? But it is in H type, where the gas exchange is severely impaired, and also by definition, the patient must have at least 15 centimeter, of water. So you can see there's a huge difference in the CT scan of the L type, where you may have ground glasses, in this peripheral, whereas you have, lungs full of fluid, and there are bilateral, consolidation. Okay, so let me summarize pathophysiology. So you have a situation that most organs are affected, not surprising, because of severe acute respiratory distress, plus the hyperactivity of cytokines. And then few minutes later, I brought to attention there are at least few papers that they are looking into, or have they looked into in a preliminary level, the contribution of bradykinin, and perhaps we have a double storms. One would be cytokine storm, and the other one would be bradykinin storm. So all of those storms, they can impact different organs, neurologic, renal, and hepatic. When I look at this slide, I immediately think of ICU. So how challenging it is for ICU folks to look into all these organ damage, and this really brings us a message, and that is the clinical management of SARS-CoV-2 infection is multidisciplinary, okay? Multidisciplinary, especially, I've seen, like between the cardiac specialist and the respiratory specialist, there is always that tension when it comes to certain cardiac medications, because the cardiac specialist wants to stabilize the heart, perhaps with higher levels of medications, but that some of these cardiac medications may have adverse effects on lungs. Therefore, the respiratory specialist is concerned. So these are some of the issues we need to streamline. As for the clinical course, this is not unknown to everybody. You're all familiar with this. The median incubation period, seemed to be between 5 and 5.2 days, and could go even, a little bit more. Well, I'm not going to go through the signs and symptoms, except, fever, cough are the two most important and common ones. About 40% of patients, they develop dyspnea. 5% may be critical. In our area, in Michigan area, this is really 2 or 3%. I'll be very happy to hear what are the representative percentage, for Merida, and about, I would say, 10 to 12%, okay, they develop severe disease with symptom. In this case, patients are severely hypoxemic, and as a result of hypoxemia, they develop diffuse alveolar damage, or we call it DAD simply, So the clinical presentation can be further discussed into 3 distinct stages. Stage 1, early infection. Stage 2, which is pulmonary stage. It has 2 subdivisions here, or 2 subcategory, followed by stage 3. And this is the severity versus the time course. Now, I don't want to go through the therapeutic options, because this is too general. It just gives you an idea how things evolve with respect to viral replication cycle, which follows, host inflammatory response. Now, is this real? No, this cannot be real. You know, there are so many intra-patients variability. And also, I would like to bring to your attention that of all these papers, you know, that we publish and all these observations we make clinically or basic science, we must also take into account the genetic predisposition. This is an area of knowledge gap. Genetic predisposition, not only in the context of patients, but also genetic predisposition in the context of drug that we give to patients and how they are able to genetically metabolize the drug, which will come in a little bit later in my discussion. But this is pretty much agreed among many experts, you know, that there is a viral phase, yes, and followed by inflammatory phase, you know. And inflammatory phase, I already discussed with you all these inflammatory markers. Now, with respect to inflammatory markers, they're pretty variable, okay? For example, here, one thing I wrote actually to the editor of this journal published, you know, IL-6 can be easily seen in especially in 2B, okay? So really, from my point of view, well, there are so many questions than answer, but what I would like to see, you know, where is the cutoff? Or if it is not cut off, where is that limitations, the space limitations, where a patient turns into high levels of, you know, for example, D-dimer. So, in other words, physiologically, it is important to establish these laboratory parameters that would give us not only how severe is the disease, but also how clinically we're going to manage it, and also in the context of clinical pharmacology. This was the slide I was talking. Keep in mind, the COVID does not have a classical characteristics of DIC. In classical DIC or acute, yes, we see D-dimer elevated, you know. In COVID, it is significantly elevated. And then some of the clotting markers, yeah, they are elevated. But we have seen in patients that they're elevated, but also they may not be elevated, okay? And in most patients, DIC patients, with respect to COVID, you know, yes, we see decreased in platelets, but they are not severely decreased. In other words, there's no that classical definition of thrombocytopenia, you know. And then you look at the fibrinogen, you know, in acute, and this is very important, in acute DIC, it's normal, but could be most likely, you know, decreased, whereas we have in COVID increased DIC. So they have two pictures emerges. One would be the bleeding, the other one is clotting, you know, thrombosis. And that's why we see thromboembolic events, you know, in COVID patients, either in the context of VTE or PE or pulmonary embolism. So what I did actually, when this was published by New England Journal of Medicine, I wrote to American Society of Hematology, and I suggested in a letter that perhaps we need to revisit the idea of DIC, and whether we need to have a new nomenclature for COVID DIC. I have not heard. Everybody these days is busy, either giving, you know, webinars, you know, or doing, you know, clinical research. or providing, consultation, clinical consultation. But I'm sure, I'll be hearing from them, and I guarantee you in the next meeting of American Society of Hematology, this topic will be revisited with them. So the consequence, the end point of clotting, disturbances would be systemic inflammatory response syndrome. We call it SIRS. Actually, that is a clinical response, okay? And what it means, that SARS-CoV-2 is capable of, and I repeat, capable of making its own or producing its own version of DIC, which this needs to be revisited. Consequently, you see organ injury, So in this level of DIC, the most important laboratory marker is D-dimer. And I will tell you, that before COVID, we all knew D-dimer as one of the cardiac markers, and coagulation disturbances or coagulopathy markers. But let me tell you, many papers, especially in the past 2 months published, really establish the value of D-dimer as perhaps a selective inflammatory marker. So this is a non-cytokine inflammatory marker, and I would be happy to hear from you in the discussion, So the spectrum of progression depends on the severity of SIRS. And this is the criteria established. If an individual has 2 of the following criterion, either temperature or heart rate or respiratory rate or WBC, that basically qualifies the definition of SIRS. But SIRS and then COVID together, they can go and further and make sepsis more, clinically prominent in the patients, and you can see one of the signs would be, decreased in blood pressure, That is the beginning, actually, once substance occurs, just like other, bacterial, that is the beginning of organ failure, Now, I am not aware if patients, they have a diagnosis of MODS, that is multiple organ dysfunction syndrome. I'm not sure if we can reverse the status, the clinical status of patient at this point. I never heard of that. I never came across, with any literature. So with respect to imaging, imagings are very important. It starts with opacities, and then you have localized consolidation, and in severe, and I've seen it actually in severely moderate, patients, bilateral, consolidation, but this doesn't specifically mean COVID. I know one group in Netherlands, they wrote a review article a couple of weeks ago, and they alluded, such pattern are quite specific for SARS-CoV-2 infection. I'm not sure at this point. I'm not concerned. I'm not convinced with one publication. I can go about that, but certainly the imaging guide you to not only better diagnosis but also prognostic. So as far as the histopathology is concerned, and this is from autopsy of patients. It's been done by Italians, by Hispanics, and a lot, actually in New York City, There are 2 patterns of histopathological characteristics. One would be diffuse alveolar damage. Okay, you see all these interstitial, spaces. The other one would be formation of thrombi. Okay, this is one thrombus information. These are multiple, we call it, thrombi. So classically, histopathologically speaking, diffuse alveolar damage, and formation of microthrombi are 2 histopathological characteristics. So where do we go? Well, we have four scenarios here, or four characteristics rather. One would be pathophysiological, okay, especially immunothrombosis leading to acute respiratory distress syndrome. We have neurotropic aspect of the virus, which I don't have time to go over, but certainly imaging can guide you to extent of damage in the brain. Then we have radiological, well characteristics, and but it may not be as specific as we want to. Then we have mechanical, okay, the ventilation issue, perfusion issue, the lung weight, the recruitability, and the ratio, or we call it, elastance. So these are some of the four distinct characteristics. As far as immune response is concerned, this came actually last month, in August issue of National Geography. And the investigators, they questioned whether antibodies are the key to go after the virus, okay? And this was based on a small study. The pool of patients was less than actually 50, all right? So they observed that there was a T-cell response in especially convalescents, patients, and also, asymptomatic, patients, But they also saw lack of antibody response. So antibody response fine, but they saw because lack of, so they concluded perhaps antibodies may not be telling the whole story when it comes to immunity. Well, that is a sort of a general hypothesis. We really need to break it down and find out what really happened to specific subsets of immune system. So here, this is a British study entitled Not Just Antibodies, B cell and T cells are important, okay? So you can see that there's activation followed, the entry of the virus and receptor to receptor interaction. There's activation of innate response, and that leads to induction of adaptive response. But keep in mind, activation is also associated with activation of dendritic cells. This is highly critical in immunopathogenesis of COVID, okay, because dendritic cells, they regulate, inflammatory response as well. So at this point, there is a knowledge gap, and the knowledge gap is memory T cells and memory B cells. So yes, from this study, it is apparent, B cells and T cells are wiped out, okay? Their levels are declining, but what level of declining means when it comes to prognosis during convalescence, not post-convalescence. So there are so many questions about this study than answers. Then another study came from Australia, okay? They looked at the T cell response, and also the antibody response, Yes, in asymptomatic, mild, and severe, although the pool of this study was quite small, but it was a good observation. They still have T cell response and some antibody response, But post-COVID or post-infection, you can see such responses are considerably diminished, This is one of the best studies I ever come across by a British group from King's College. They looked at the immune signature profile, okay? For example, they measured, this was a very elaborative study from a large group of patients, as a matter of fact. So you can see the plasma cells percentage, it's quite scattered, but while it is quite scattered, it cannot reach higher level, okay? Then with respect to glycoprotein spike and their representative antibody IgM and IgG, you can find typically two responses with respect to different population, a little bit of intermediate here, whereas IgG, again, there are two responses, major responses here and here, but you see pretty scattered intermediate as well. So what it means a lot. We can discuss it, during discussion. I don't want to go because I'm getting close, to my presentation. So this study further elaborated on the expression of immune markers, especially IL-6, IL-10, and then interferon introducing, proteins. You can see the extent of expression and the level in COVID patient is significantly higher with higher frequency, both sides, let us say just with compared to lower respiratory tract infections. So this really is an excellent data, comparative data, telling us, the respiratory syndrome or in COVID is much more complex than other bacterial or viral, respiratory infections. They also did a assessment of ventricle cells, okay, and on this slide you see the level of actually plasmoid ventricle cells are lower, and even some patients didn't express, at all, So that is very, concerning, because as you know, plasmoid cells, they are involved, not only in immune response, but also in secondary infection. Their role is very, important. So the take-home message from this particular slide is, yes, there are monocytes and ventricle cells, and they have disrupted phenotype expression. And then another study came, and this study was, by the way, by Swedish group, okay? And the Swedish group delineated that while in acute phase of infection, contribution of CD8 is important, but patients also develop CD4 response, okay, which are complementary response. So what is interesting, they measured, not only the response of T cell. Forget this one, I would like to elaborate in this area, okay? An exposed person, mild disease and severe disease, So you could see that there is a slight increase in T cell response and maybe a better and sharper increase, in production of antibody. So again, this was an Australian cohort, And then, in a Chinese study, okay, they did similar profiling the immune system. Their finding was, the level of T monocytes are decreased, as well as ventricle cells. So their hypothesis was that this viral infection leads to rapid deficiency of ventricle and T cell functionality. Now, we haven't seen that actually in the previous slides or previous studies, but again, these are, let me go back. These are, quite a little bit different than the previous result. So to just summarize, the immune response, yes, there is actually both T cell and B cell immune response. But the question is, their responses are short-lived. And when it comes to antibody response, especially IgM, IgG, yes, it peaks around 4 weeks, and IgG peaks around 7 weeks. But you can see then there is a sharp decline, especially IgG. There's a sharp decline. And that leads to speculation whether a secondary infection or vaccine might be effective or may not be effective, okay? So that is a real issue, okay, and that's why we are waiting for it. Our vaccine program's a little bit halted, as you probably read yesterday. Even Johnson & Johnson halted because of some toxicity issues and some adverse effects, especially in one patient. And now FDA is very vigilant, very cautious, so they asked Johnson & Johnson, to go back and revisit, their vaccine protocol. Do I have a little bit more time to go over clinical management? Just 5 minutes?
Well, yes.
Thank you.
Interesting, yes.
Thank you. So let me give you an insight. I'm sure you tried it in Mexico and in Merida, Yucatan as well. Currently, remdesivir shortens hospital stay. 3 to 4 days, that's fine, but really we don't know yet, what is the correlation of remdesivir activity with mortality. I would like to see more data on that. Favipiravir, that's a Japanese drug, there's a lot of positive comments about favipiravir, but again, there isn't really a large clinical trial, double-blind placebo clinical investigation of it. This has been really no effect at all. As a matter of fact, this morning, I read about it again, and the combination of lopinavir-ritonavir. Please ignore it, and it has no effect whatsoever. We come to different classes, such as dexamethasone. You all heard about the British study and how that British study immediately went throughout the world, and suddenly everybody is adopting the dexamethasone, either in tablet form or IV, okay, or even betamethasone. Well, in question and answer, I would like to discuss a little bit of dexamethasone, but just to be on safe side, with all these immune dysregulation, dysregulation of monocytes, dysregulation of phenotype expression, and the different drivers of the loss of immunity, you would really wonder what would be the wisdom of using dexamethasone, okay? Let alone dexamethasone in early stage may complicate the disease. And, keep in mind the early stage of the disease, anti-inflammatory is not recommended because it's just a virus, unless, the patient has so much comorbidities, that may start, showing, a little bit of inflammatory response, Our president took this regimen or cocktail, polyclonal cocktail, and he says that he thinks good. And then we have hydroxychloroquine. I have many experience on hydroxychloroquine. Hydroxychloroquine is a double-edged sword. It depends, your experiences. I'm sure some of you are rheumatologists in the room that can elaborate on that, and it's not that nasty as you will see in the literature, in the COVID literature. Hydroxychloroquine has its drawbacks, but also has its advantages. Again, we can discuss it during discussion period. The role of antibiotics. At the beginning, many hospitalists, and even primary care, they were mixing these two together, hydroxychloroquine and azithromycin. Some patients developed QTc interval, prolongation, and because both can cause that, So in a situation like this, maybe, doxycycline, 100 milligram per day would be better. Plus, doxycycline has a little bit more anti-inflammatory effect compared to azithromycin, And going back to hydroxychloroquine, the prophylactic aspect is another, thing that we need to discuss it today. Then we have IL-6 antagonist, Currently, there are few NIH experimental studies and clinical trials going on. When I did the consulting with Brazilians, and Turks and Italians early on, in some patients, they were happy with the administration of IL-6 antagonist, and in other patients, it didn't make any difference at all. The role of colchicine, it's not really clear. Ivermectin, I have collaboration with Federal University of Para in Belém, Brazil. And at the beginning of epidemics, we were discussing this medication because it's very cheap and wouldn't cost you much, And we know now that this medication is quite ineffective in the later stage, once that cytokine storm kicks in. But in early moderate stage, may be beneficial. Again, our conclusion was observational. We did not really design any randomized clinical trials. Role of interferons, yes, the production of interferons are severely suppressed in COVID patients, but there are some reservations on interferons, especially from adverse effect point of view. And Chinese, at the beginning, they were using it, but now they have some second thoughts on the use of interferons. With regard to anticoagulants, yes, there are inflammatory and also coagulation markers based on the severity of those markers. You really need to move on anticoagulation, either heparin or low molecular weight heparin. I prefer this one because this has a predictable pharmacokinetics than this one, and plus it kind of bypasses some of these drug interactions. So what are the challenges? Well, keep in mind, we are using repurposed drugs. None of these drugs, including anti-inflammatory, are designed or approved by FDA to be anti-COVID selective specific medication. So we are using repurposed drugs, and these repurposed drugs basically were not designed to address a new viral illness. Its epidemic devastated the whole world. And keep in mind, it has so much complex pathophysiology that if we do not, I repeat, if we do not fully understand pathophysiology, we won't be able to design selective drugs. So the role of clinical pharmacology is important. Some of these repurposed drugs we're giving for COVID patients. And keep in mind, when they end up in ICU, most of them, they have severe renal disease, okay? So then the issue with these repurposed drugs, do we really know much about their pharmacokinetics behavior? Do we really know about clearance of these drugs or pharmacodynamics, which can cause drug-drug interaction? So there is more knowledge gap than questions, okay? So the role of clinical pharmacology is to make assessment and impact. And most importantly, we need to validate and standardize therapeutic regimen, okay? And especially, we need to come up with a therapeutic regimen for the beginning of the disease at the hands of primary care physician. For example, remdesivir is not good when you're staying at home because it's an IV. Unless you have a nurse, you bring a nurse home. But again, that's the liability issue, okay? At least here in the United States, So would it be possible to make a tablet formulation of remdesivir or new antiviral? I would like to hear from you. So the bottom line is we should not put patients in harms. So there are two take-home message from this webinar. Number one, pathophysiology, including immunopathogenesis, is very complex. We need to go back to fundamental research. And it is only through fundamental research, okay, you can translate into clinical practice, or we can set up clinical trials of the patients, okay, in the hospital setting, where we send samples from patients back to basic science lab. Again, that is one way of translation as well. Translation is bilateral, basic to clinical, clinical to basic. Number two take message is that currently we do not have any selective drug. Therefore, I think as long as I am alive, in addition to vaccine, others, even if we come up with the best selective, specific antiviral drug against COVID, yet clinical management of COVID is multidisciplinary. Muchas gracias. Okay, go ahead with your question.
Well, there is a question on the chat regarding overuse and abuse of antibiotics and if that influences the presentation of COVID as diarrhea.
This is an excellent question. Wow, I'm excited. I'm excited to answer. Well, we know for fact that abuse and overuse of antibiotics, they impact microflora of the gut. And as you know, the Americans are the highest consumers of antibiotics. As a matter of fact, a few years ago, I was in a conference and I compared the consumption of antibiotics, US population as opposed to, let us say, Asian population. Also keep in mind, I have been in Mexico many times and I have so many collaborations. In Mexico, it is not difficult to get hold of antibiotics, okay? And let alone antibiotics are used not only in poultry sciences, but other agricultural sector, and antibiotic resistance through gene transfer, particular plasmid, is really a deep issue in global health. Yes, those patients who have had unnecessary antibiotics, either abused, misused in the past, they typically develop more severe disease. And it makes sense because the GI has the highest percentage of once the microenvironment of the gut changes, that predisposes actually more receptors to the virus.
Ok, hago una síntesis de la respuesta. La pregunta fue si el uso de antibióticos está impactando en el cuadro clínico y en la presentación como gastroenteritis. La respuesta es que sí. Hay que reconocer que el uso de antibióticos tiene un impacto definitivo en la microbiota, y esto es microbiota intestinal, y esto es tanto por el uso de antibióticos como por el uso no advertido de antibióticos en la industria alimentaria. Esto sí se asocia, según la observación del doctor, a cuadros graves, y considera él que se debe en cierta medida a la expresión mayor de receptores de ECA a nivel intestinal, que expresan más incluso que la mucosa o que el tracto respiratorio, y que esto permitiría quizás un ingreso de mayor cantidad de virus y por lo tanto una respuesta más intensa. There is a question as well regarding whether those patients, particularly children with allergies or asthma, tend to have a different immune response and then a more severe clinical course.
Another excellent question. As you know, children in general, they do not develop severe disease. In New York City, during epidemics, we experienced about 9 children, they developed Kawasaki-like syndrome, which necessitated IVIG infusion. So in that subset of children, we need to look into their genetic, their predisposition, And why is it they have developed severe form of the disease leading to Kawasaki-like syndrome? And the other one thing is that perhaps these children, they had some kind of primary immune deficiency syndrome, but not they were not clinically diagnosed.
La respuesta a la pregunta acerca de los niños con rinitis alérgica o asma bronquial, el doctor dice que claramente se sabe que los niños tienen cuadro clínico más leve, aunque algunos de sus pacientes han presentado una mayor prevalencia de enfermedad de Kawasaki, y surgen preguntas si existe alguna predisposición genética. También se está mirando la posibilidad de si quizás algunos pacientes que han presentado cuadros clínicos de mayor gravedad tengan relación con alguna inmunodeficiencia constitucional que no haya sido diagnosticada, pero que haya explicado el cuadro clínico del paciente. There is a question as well on regarding, I'm going to give you one or two questions and that's it because of time. There is one regarding persistence of symptoms after infection. There is one regarding whether treatment with ACE inhibitors would cause a different clinical course. And let me see.
Yeah, as you saw from one of my slides, ACE inhibitors and ARBs, currently the recommendation of American Heart Society is do not change the drugs. Let patient take ACE inhibitors. And the reason is that at the beginning, we had information from China, at least, you know, that there is a receptor upregulation, okay? But again, when you are taking ACE inhibitors, you're not really targeting ACE2 specifically or directly, you know. The target is ACE1, you know, enzyme. Yes, there are some studies, they indicate there is higher expression of ACE2 in hypertensive patients and in other conditions. But really, we don't know what this higher level of expression mean. Does it mean strictly frequency? Does it mean strictly higher percentage? Or does it mean anything else that we at least don't know about it? So whether it's upregulated receptor or downregulated, at this point, we do not have enough clinical data to lead us to believe that we must change either ACE receptor, ACE inhibitors, you know, or ARB medications.
Okay, la respuesta de los inhibidores de angiotensinos, los pacientes que reciben este tratamiento no necesariamente está demostrado que tengan un curso clínico difícil. Esto está relacionado con el hecho de que el COVID tiene una mayor actividad o requiere al IECA tipo 2 y el tratamiento con inhibidores de enzima de angiotensina es no selectivo. Por lo tanto, esto no implica que los pacientes vayan a tener una evolución diferente porque estén recibiendo el tratamiento aún en el caso de que se sabe que hay una sobreexpresión del receptor. Voy a hacer, por obvio del tiempo, una última pregunta y con esto vamos a cerrar. La pregunta la hago en español primero, es acerca de la probabilidad de la vacuna. El doctor tiene un artículo publicado en Archives of Healthcare que habla de una posible menor eficacia de los pacientes de la vacuna en los pacientes de mayor edad, lo cual también se ha observado en los pacientes con influenza, y que yo que comente acerca de esto y de una propuesta que él hace en su artículo de que se pudieran desarrollar vacunas específicas para grupos etarios. The last question, Doctor, would be regarding an article that you published in Archives of Healthcare recently that speaks about efficacy of vaccination in the elderly. And then you comment on having a similar experience with the flu vaccination that is less effective in those patients, those elderly patients. And you propose the likelihood of having a age-specific vaccination. Would you please expand on that?
Okay. Well, I'm glad Mexican doctors are following me. They found my publication, you know, with actually two universities in Iran, in Archives of Healthcare. Well, in that editorial, we made a general opinion, okay, based on, as you know, we have a retrospective study. Certainly, in retrospective vaccination, let us say in this case, flu vaccine, those primary care physicians, they are involved in vaccination. They can tell that the highest efficacy we had ever in the United States, even in your country, Mexico, was 40% efficacy of the virus. Yeah, these days the biopharmaceutical companies, they're aiming at least 50% threshold of efficacy for COVID vaccine. But again, we haven't even gone through phase 4, and some of them even have problem in phase 3. And this really tells us that we may not even be able to start vaccination in December, as many public health officials, in the United States believe so. In that article, I'm glad you mentioned that we specifically elaborated on not only the safety but also efficacy. So the question is, the elderly population, I was not able to discuss it today because that's called elderly immunology. It's a different type altogether. Is that they don't typically respond to vaccination, at least in our experience, And so does that mean that the future COVID vaccine shouldn't be used for this population? Or does it mean that we use it, but it should be divided in different doses? We call it booster shot. So there are so many questions in this area of vaccination. We can't really answer until the vaccine comes to community. And I was talking to a French colleague a couple of days ago, and we were discussing it because he, like me, he was a trainee of Pasteur Institute, and we know each other many years. We made it clear that maybe this is a type of vaccine needs a booster shot. Okay, and then we also made it clear through conversation that when you are in R&D phase, your patient's pool is selected. Okay, the true vaccine, the real vaccine, should go out in the community. So what I mean in community is that a community comprises of different age, different ethnicity. When I say ethnicity, because some of these may relate to a genetic predisposition, okay, or genetics of the certain race, to either, take it or reject it, So there are so many, I love medicine because of the social aspect. This is a particular social aspect of medicine that you see there is an influence with respect to vaccine products and how efficacy of vaccine, can be evaluated. So until such vaccines are not distributed in the community, different race, different colors, different age setting, different comorbid conditions can take it. And it is only through then we can use the capabilities of supercomputers, okay, which are very common. Super meta-analysis are very common these days, especially I've seen a couple of articles, on COVID, Then we can come up with the certain degree of confidence interval, that p-value, that whether this vaccine is number one, safe, and number two, it's effective. So back to this doctor who asked the question, we really have a long way to go. My prediction is year 2021 would be assessment of the vaccine in the population, and perhaps year 2020 would be a year that we will have a better understanding of vaccination in the population, not in individuals.
Yeah, thank you. That was my question, actually. La respuesta de la vacuna pues no es muy esperanzadora. Dice que efectivamente en influenza los estudios que han evaluado la vacuna han demostrado una eficacia cuando mucho del 40% en población norteamericana y que esta eficacia es menor en la población de mayor edad. están apuntando los estudios a una eficacia que ronde el 50% para la vacuna de COVID, pero todavía no hemos llegado ahí porque los estudios están en fase 3. Él considera que con la información disponible no es viable la vacunación en diciembre, aunque los diferentes gobiernos lo estén anunciando así. También menciona que no es solo la eficacia de la vacuna, también es importante la seguridad de la misma, que se sabe que las personas de mayor edad no responden bien a la vacuna y que esto hace surgir preguntas tales como si será que la vacuna sirva o no sirva, y si será que la vacuna en este grupo poblacional requiera quizás de más de una dosis para tener eficacia. Que tampoco es lo mismo lo que se obtiene en estudios controlados en donde la población es seleccionada al comportamiento de una vacuna en la población abierta, y que hasta que se tenga en población abierta y se aplique a diferentes poblaciones con diferentes ancestrajes genéticos, con diferentes grupos de edad y comorbilidades, es que se va a poder saber si la vacuna funciona o no y qué tanto. Y que él prevé que el año 2021 será un año en el que se va a evaluar la eficacia real de la vacuna ya en su aplicación, y que quizás hasta el año 2022 es que tengamos un conocimiento suficiente del comportamiento de la vacuna. Lo siento, pero siguen surgiendo las preguntas. Yo creo que podríamos tener para 3 horas con el paciente, con el doctor. Le voy a preguntar si podremos contactarlo con preguntas adicionales por otra vía, pero por obvio de tiempo tenemos que cerrar la participación del doctor y proseguir con los siguientes dos ponentes. Thank you, doctor. There are a lot of questions.
Thank you so much. It was a pleasure, especially give my salutations to Hospital Uharan. There are many doctors over there that know me. By the way, before I finish my talk, and there is a question for me. If antibodies are not solution, should we investigate what? Investigate. Can you elaborate? Investigate what?
Yeah. While this person does that, I have a question for you regarding whether we can contact you in another way.
Yeah, I think it's better. I would say collect all questions, yeah, and then I will address them.
Yes, and then we will find a way in which to provide them with the answers.
And also, alternatively, we can have another COVID seminar in the future.
Okay, thank you very much.
Muchas gracias.